Hi, this is Dr. Mark Skeen, Associate Professor of Neurology at Duke University Medical Center and head of the Multiple Sclerosis Clinic there. This is another in a series of videos just trying to make information available to folks. I want to call this video an overview of therapies. So I did a previous video that sort of talked about our philosophy of treatment. Now what I want to do is talk to you about the various medications. And this is very much an overview and very much my opinion. I'll mention why that's the case momentarily. So I would again urge you to chat with your physicians and your MS care providers because they may have different views of the medicines than I do. And you should certainly get your advice and have them help you make decisions rather than listening to anybody on the internet, frankly. But for what it's worth, I want to give you my overview and you can take it or leave it. What I want to say is a couple things. A disclaimer is that no pharmaceutical company is involved in this video or anything I'm going to say. Some of them will be happy with what I say, some will be unhappy with what I say, because some of it's going to be opinions about their products, and not everything I say has been proven. So I'll try to indicate what is and what isn't proven, but a lot of this is my view of the medicines, but different experts who are smarter than I am could have a different view. So you just need to understand that that's the case. Another disclaimer is that I do consult for, speak to, advise, and sometimes do non-promotional talks for pharmaceutical companies. So I am not uninvolved with the pharmaceutical companies. So if that influences your view of what I have to say, that's fine. So this video is really going to be very similar to a conversation I have with patients early after they've been diagnosed with multiple sclerosis. And my goal is to give people an overview of multiple sclerosis medications. And there's no way to communicate rapidly all the detail. And so really my goal is to help people know what the issues are with our various disease-modifying therapies for multiple sclerosis. So a lot of what I'm going to give you is opinion because we don't have good evidence. There are things we do have good evidence for, but a lot of times the trials that allow these medications to be approved by the FDA or the EMEA in Europe compare the product with the placebo, for instance, or with one other medication. But we often don't have direct comparisons between these medicines to know which medication is more effective than the others. And I would say history has shown that we're not so smart about it either, that many of us had opinions about the early injectable disease-modifying therapies that when they ultimately were compared head-to-head, we found out our opinion wasn't so well substantiated. So everything we think we understand about the relative efficacy of the therapies, I think we have to understand and we take with a grain of salt. Having said that, I'm getting ready to tell you what I think. So when I talk to patients about the medications, I talk about sort of three large groups. One is the injectable disease-modifying therapies, which are the beta interferons and glatiramer acetate, and the brand names are Copaxone, Betaseron, Avonex, Rebif, Glatopa, and I've forgotten something. Sorry about that. But anyway, the drugs which have been around for a long time. And I describe to my patients that these are effective and tremendously safe medicines, but I would consider them modestly effective. Why do I say that? Well, if we look at the easiest to measure indicator of efficacy is how many relapses do people have. The data for these injectable disease-modifying therapies is that they stop about a third of the relapses that people would have had anyway. Now, in any one person, we don't know how many relapses they're going to have. But in any case, stopping about a third of the relapses that a group would have had, I would say that's a modest benefit. It was great when they first came out because now we finally had something that worked. But I think we have evidence to suggest that many of our newer therapies are more effective, and therefore I would consider the injectable disease-modifying therapies, on average, as modestly effective medications. We also now have 3 oral medications approved for MS in the United States. My personal view, and this is opinion, is that 2 of those medicines seem to be more effective than the injectable disease-modifying therapies. And I would consider fingolimod, which is Gilenya, and dimethyl fumarate, which is Tecfidera, as probably more effective than the injectable disease-modifying therapies. The third medicine, teriflunomide or Aubagio, may be more effective than the injectable medicines as well, but to my review of that literature, it's less convincing. In any case, these are effective therapies. They're oral. They don't require injections. And so for those reasons, they certainly are more preferable for many patients than the injectable disease-modifying therapies. We also have a number of intravenous medications, and as a group, I think they're tremendously more effective than the other medicines. Natalizumab is Tysabri, is an incredibly effective medicine that's been around for years. Our most recent FDA-approved medicine is called Ocrevus, or ocrelizumab, which has just been out since the end of March of 2017. I think is likely an incredibly effective medicine as well. The data would suggest so. Our experience is not adequate enough for us to judge by our experience yet, I would say. It has the added benefit, I would say, of showing modest efficacy in primary progressive MS, and it's the only medication which has been shown to have statistical evidence of benefit in primary progressive multiple sclerosis. The other intravenous medication that is, I would say, very different but very exciting is alemtuzumab or Lemtrada. And it's a very powerful medicine that we give. I should have said that with natalizumab, we give infusions once a month. With Ocrevus or ocrelizumab, the first 2 infusions are 2 weeks apart, and then it's every 6 months. With Lemtrada or alemtuzumab, we give 5 infusions in the course of a week, then nothing for a year, which then we give 3 infusions 3 days in a row. And then the goal is to not give any therapy for years. And for many people, they can go years without additional signs of multiple sclerosis activity. So it's a very exciting medicine. So you might say, well, and I would say, that's clearly the inductive approach. That's the induction of remission, and it's very exciting. So you might say, well, why wouldn't everybody use that therapy? I would agree. The why is that it turns out that with our more efficacious therapy, there are also some risks, and it's always weighing the risk and the benefit. With alemtuzumab or Lemtrada, the primary risk is that it's a very immunosuppressive medicine, and we're worried about rare, weird, or unusual, what we call opportunistic infections that occur in the immunosuppressed state. In addition, about 40% of people will develop other autoimmune complications because of the therapy. Now, it occurs years after the dosing. The good news is that the primary autoimmune complication is autoimmune thyroid disease, which is a very common problem anyway, and is generally very treatable. But in addition, autoimmune destruction of platelets can occur and autoimmune damage to the kidneys. And before we were aware of all these complications, one person died from intracranial hemorrhage, a hemorrhage in the brain, because of the destruction of platelets, and at least one person required a kidney transplant because of kidney damage. So these are very concerning long-term side effects of having gone through that therapy. As we use it now, that medication, we do blood tests and urine tests regularly for years, and we think that by doing so, we can uncover and understand these complications before they're serious and treat them effectively. So we're quite hopeful that these long-term complications can be minimized. Going back to the other medications, Tysabri I mentioned, or natalizumab is its generic name. It's a once-a-month infusion. It also is very effective. Its primary problem is that it can cause a terrible condition called PML, progressive multifocal leukoencephalopathy, and that's why we call it PML. And I'm going to give a whole nother video regarding PML and our thoughts about it. PML has also been seen with other immunosuppressive medicines, including the other MS drugs, Gilenya and Tecfidera, but very, very rarely. Tysabri is the only medication in which the incidence is very high, and it really becomes a significant issue in how we use it. And like I said, I'll do a whole nother video about PML and the MS medications. With all of our medications, I should mention one other medication. There's another newer injectable medicine called Zimbrida, or diclizumab is the generic name. It's also a rather effective medicine. I would personally place its efficacy at about the same as the pills, the oral medicines, or between there and the infusions. It's a once-a-month injection. Most people, in our experience, tolerate it very well. It can cause liver damage, and that's our main concern in monitoring, is to avoid liver damage. So that may be an adequate overview of those various medications. Each of the medications has its own safety issues, so we don't just plunge into these medicines without concern or paying attention to the individual risks of our patients and the severity of their disease. Obviously, the folks that are going to benefit the most from very powerful medicines are the folks whose disease is the more active. And so there's a lot of sort of complicated decision making, and we talked a little bit about that in the previous video, and I'll discuss more specifically in the next video about how we think about PML, progressive multifocal leukoencephalopathy, and how it influences our decisions about how we use multiple sclerosis disease-modifying therapies. Thank you.